راح أبدأ بالضبط إحنا. أوكي، السلام عليكم. أنا الدكتورة نرمين هلال. My name is Dr.Marmin Helal. Special thanks to Dentoscope and Dr. Hay for inviting me to speak to you today. It's a great opportunity. I hope it will be beneficial for most of you that are interested in orthodontics. A little about me. I graduated from King Abdulaziz University a while ago, and I applied for a postgraduate study at Jacksonville University in orthodontics, and I pursued my second postgraduate studies in pediatric dentistry at Children's Hospital of Pittsburgh. And then I pursued further studies in public health as well. So that's about me. I hope I can answer some of your questions today. Dr. Haif sent me a couple of questions that we'll be addressing today as well. So I'm moving the camera to the screen, and please let me know if it wasn't clear. 1 second. Here you go. Is it clear? Okay, so a little about interceptive orthodontics. First, what is the definition? So interceptive is an adjective form which means obstruct someone or something so as to prevent them from continuing to a destination. So basically what you want to do, you want to prevent problems from happening. In general, your first orthodontic checkup should be no later than age 7, according to the American Association of Orthodontics. So basically you're spotting subtle problems with jaw and emerging teeth while some baby teeth are present. You want to begin treatment at appropriate time. So what are special consideration in early treatment? First and the most important is timing. Okay, you want to start in the correct time, not necessarily early, but in the correct time. Because if you start too early, sometimes your treatment can drag for so long, and this is the dilemma most pediatric dentists actually face. Or sometimes seeing problems but not addressing it early enough or at the right time can lead to for these problems to actually progress and more complex treatment. And I actually put a case example for this situation. So the objectives has to be clearly outlined and understood. That's another issue that I really want most of you to consider all of you to consider while doing treatment, that your objectives has to be clear, why you are starting this now and not doing it later. Okay, so first, when you see any problem, you have to formulate a problem list. Okay, how do you formulate a problem list? By taking a proper history examination and proper records collection. It is a very good habit to develop, especially very early in your career, because if you just depended on your clinical examination, you might lose some important data. Okay, and then you go for your orthodontic assessment. Your orthodontic assessments usually has to be in 3 dimensions, AP, vertical, and transverse, and you have to address it. All of these, you have to address all of these dimensions in skeletal and in dental and in soft tissue. So, general, you have the orthodontic problems that you want to see and intercept, usually dental, and some skeletal problems. Very important to diagnose this problem. Is it dental or is it skeletal? Because the management will be tremendously different in both situations. So what are the factors to be considered? Initial malocclusion, growth of the patient's primary concern and chief complaint, treatment limitation, and of course, again, I repeat myself here, treatment objective. So I'll give you some clinical example. Okay, so for the facial form, if you look at this face, you see here that this patient has a long face. So she is dolichofacial. For example, in order for me to address anything in this case, I have to be close attention to the vertical dimension of this case. A dolichofacial case or a long face is definitely can impact your management. If you look here, this kid, he is mesofacial, he's within normal limit. So I know that he's vertically not that sensitive, so I'm not very concerned about that, so I can focus on my dental problem. If you look at this case here, this is a brachyfacial form. Okay, so she's a deep bite case. So if she has a dental problem, okay, I might want to be close attention to the vertical dimension of this case. If you look here, okay, if there is an asymmetry, okay, you want to be close attention to that, because some cases has hemifacial hypertrophy that you're not aware of. Some cases have hemifacial microsomia in a milder form that you're not aware of. Any congenital defects, cleft cases need special attention. Unilateral condylar hyperplasia, unilateral ankylosis, and facial palsy. Okay, this is a hemifacial case. Okay, you see the canting of the occlusal plane. Even dental treatment can be affected if you're placing crowns or restorations in this case. Condylar ankylosis, limitation in the mouth opening. How are you going to restore the teeth of this case? As a general dentist or as a pediatric dentist. Congenital defects, clefting, and this is a very big and wide topic. We might address it some other times. If you look here, facial profile, okay, there's straight facial profiles, there's convex and there's concave. There's not much you can do about facial profiles very early. However, in some cases, like this here, this concave profile, you might want to improve sometimes if you're going to do some dental treatment for this case. Okay, how do you assess the Aap relation? Usually, we can do the two. You can do the two fingers test by placing the index finger and the middle finger, the index finger on point A, the middle fingers on point B. If it was pointing downward, usually this means that it's convex. If it was pointing upward, that means that you're probably concave. First is class 2-ish, second is class 3-ish. Okay, another way of assessing the vertical skeletal relationship in this photo is from actually Laura Mitchell, which I highly recommend for undergraduates and pediatric dentists. Profile photos of two lines crossing the occipital region. So if you look at this patient here, this is the occiput right behind the ears. Basically just hold the mirror, okay, right along with the mandibular plane angle and with a Frankfurt horizontal. And if you look at that, that can tell you that this patient is vertically sensitive or has a high angle. Okay, so here again, relationship. FMA is a Frankfurt to mandibular plane angle, usually if they intersect at the occipital region, so right behind the ears, that means that it's an average growth. If it meets far beyond the occipital region or does not meet at all, that means that this is a horizontal grower. And if you have a very high okay, we're back. I'm sorry, it keeps disconnecting for some reason. Or if you have a very high mandibular angle, means anterior to the occipital region, it means that we have a vertical grower. So can you tell what vertical dimension is this patient? Is it increased, decreased, or normal? So this patient here is actually high angle. You can see also, I can show you with other signs like the mentalis strain, for example, or by examining the chin furthermore. Okay, so if you look here at the mentolabial sulcus, okay, if it was normal, it means usually this patient roughly is angle class 1. If it was shallow or we don't have a mentolabial sulcus, it means we have bimaxillary protrusion. If it was deep, it means he's angle class 2. Okay, if you look here, this is normal, this is shallow, and this is deep. Also, the chin position and prominence can tell us information about this patient. Prominent chin, usually it means skeletally class 3 malocclusion. Recessive chin, it means skeletally class 2 malocclusion. If you look here, this is normal, prominent, and recessive. The puckering of the chin, like I mentioned before, can also give us an indication of the vertical dimension of the patient. Okay, asymmetry. Asymmetry can be due to functional shift, like in this case. Different forms of lip, competent lip or potentially incompetent lip, and everted lip. Usually, if the lips were in contact on muscle relaxation, that means this case is angle class 1 malocclusion. If it was potentially incompetent, it means lips are in contact, which means that the patient is on class 1 malocclusion. Incompetent lips when we have no lip contact present, and that means this case is a skeletal open bite case. Everted lips, usually in hypertrophied lips, class 2 malocclusion or bimaxillary protrusive. Everted lips or hypertrophied lips in class 2 malocclusion or bimaxillary protrusive cases. So for the intraoral examination, we want to look at the tongue, at the frenal attachment, at the palate, gingiva, and occlusion. Like this case, we have a cleft. Okay, so the management of cleft is definitely different. We have diastemis, like in this case, or frenal attachment. Cross bites, and this is a very wide topic that everyone should be aware of because it can prevent a lot of complications later on. Open bite with eruption problems. Anterior cross bite with tongue thrust habits. Posterior cross bites, is it unilateral or is it bilateral? Delayed incisors. So radiographs are very important because it can give us a valuable information. Simply by counting the teeth or looking at the teeth eruption sequence. Accidental findings, you can find supernuums, missing teeth, ankylosis, primary failure of eruption, TMJ, and paraoral structure. If you look at the span over here, you can see here there's a supernumerary tooth, and this is the permanent incisor. So sequence of eruption is very, very important. Or 4 o'clock patients that you look and you count the teeth and you don't see the 5s, the E's, and then you take a pan and this is what you see. See impacted or ankylosed E's. And a supernum. On your bite wings, regular bite wings, and you see this severe ectopic eruption. So all of these varieties of orthodontic problems that can be intercepted and prevented early. So when to refer? As a general rule of thumb, when you see any discrepancies, severe high angle, open bites, low angle, deep bites, discrepancies in the sequence of eruption, and this is very, very important because I see a lot of cases that the dentist did a lot of work for and never cared enough to to refer this patient for an impacted center. Reversed overjet, excessive overjet, deep overbite, posterior or crossbite, and habits. And these are the things that I show a little bit of clinical pictures from. So does what you see on the outside correlate with the inside? And I always teach this to my residents. If you see a high angle case, you know, you want to look inside for an open bite. Any extremes that might pose a problem that warrant an early consultation. So those are general indications for early treatment or referral: a posterior crossbite, anterior crossbite, single anterior tooth in a crossbite. And this is very easy. You can, as a general dentist or a pediatric dentist, you can easily correct that. Eruption problems, class 3 skeletal pattern, and habits. And functional shifts, of course. I will try to do another live stream if I saw a case with a functional shift. Inshallah, I will show you how to examine the presence of a functional shift. I have a couple of videos, but they're not of the best quality, so I don't want to share it. I'll probably share it on a clinical exam later. Okay, I want to show this case. This is an example of a case that you can actually intervene early to solve this problem. So this kid came for regular dental work, and I want you to take or be a close attention to this lower arch. Okay, so what do you see here? You see boned out sixes, okay, and you see carious teeth. And look at this. This is the canine, lateral, central, and then we have primary lateral incisors and canine. And look, where is your lateral incisors, your permanent lateral incisors? Okay, take a close look at the pan. You see here, those are the interiors, and then this is the lateral incisors, and this is the canine. If you see something like that and disturbance of that sequence of eruption and location of the teeth, then you might suspect something else. This is a very good case to refer, and I kudos to the pediatric dentist that actually refer this case at the correct time, recognizing the need for Okay, so the BCT to see where is the location of that canine. If you look here, see, I wanted to see where is this exactly, so we know where to move our teeth. Okay, so look here. This is your lateral, and this is your canine, and those are your baby teeth. So my canine is actually buccal or facial, and that's very good for us because we know now the direction of pull, or where we're gonna pull that tooth and put it in place. If you just extracted the teeth, the primary teeth, without any intervention, if you look here, so these are the baby teeth, this is the canine, and this is the lateral incisors. So what will happen if we just extracted the baby teeth? I'm going to put the case back. So if we just extracted the baby teeth, what will happen is that the canine will basically erupt into a complete transposition. Okay, and this is actually a bad thing because you will lose all of your canine guidance. So what is the solution for this case? The solution for this case is to basically put 2x4 appliance, a fixed appliance, and I'm going to show you also in another live stream how to put that appliance. It's just fixed brackets basically, and the direction of pull will be from the lip to pull this tooth into a position. Again, so the importance of putting a problem list or an objective list, okay, is not to have tunnel vision. So I don't want us just to correct this problem without or with overlooking the upper arch, where I have maybe less of a severe problem of space loss, but still, if I'm doing early treatment in this case and I'm correcting this big problem of transposition, is actually to fix this as well. So we're doing a 2x4 on the upper arch and on the lower arch. We will correct the transposition and the moderate space loss that we have on the top. And this is why your problem list is important. Okay, I'm gonna show another case. I'm gonna show another case before I move on to the oral habits, because actually someone asked about this. Because someone asked about the oral habits. They wanted me to address that. Okay, so here's Elaine. I'm gonna show you this case. She's an 8-year-old, and she had a history of trauma to the baby teeth, which affected the positioning of the upper anterior teeth. And this is where history comes in handy, because it can help you to know if you have any dental problems. It can help you to recognize or know the source of this problem. Is it skeletal or dental? And I will explain this to you here. Okay, so she had a history of trauma for the upper anterior teeth, and she comes in for a clinical exam. And if you can see, I put this case before for the examination, and we agreed that this case is actually a high angle case. But look at the position of the central incisors. If you see here, so you see an anterior crossbite, and that most likely dental. Is not a skeletal crossbite, because of the history that she has, because it's also a single anterior tooth and crossbite. However, if you look here posteriorly, she has a maxillary constriction, and that has nothing to do with the trauma or with the history of trauma. But what I don't want you to overlook is just by looking here, you see a crossbite here and a crossbite here, and you forget to look at this upper arch where she has actually not enough space for the lateral incisors to come in. And if you take a look on the pan, I don't want you to miss another problem, which is very high canines right now, but I will show you an x-ray later of a potential for canine impaction. So this is an example of how I do my cases. I always put a problem list and a treatment objective, and I want to thank Dr. Jihan Khan for doing this case with me. She's a PhD student. She's an excellent PhD student. So first we put a crowding, no space for upper canine. So we wanted to resolve some of this crowding, because usually crowding is not of the main things that we address in phase 1, but we are doing this in this case because we are preventing the laterals from becoming impacted. And then we have the crossbite, and she has the functional shift, and she also has this high angle issue that she has. And this is our treatment plan, and I'm just going to show you quickly. So in this case, she needed expansion. I like to put I chose bonded expander because of the high vertical dimension, or the high angle, because the high angle skeletal pattern. If you did just regular expansion, what will happen is that you will open the bite in this case, and you will end up this patient looking even more high angle, or she will look even more vertical. And you don't want that. You want your orthodontic treatment to improve the facial, not to make it worse, just correct the occlusion. So you always want to be attention to all of those details. I like to put brackets on my bonded expander in case I needed to do a 2x4. And at the same time, because I know that the problem in the anteriors is actually a dental problem, is not a skeletal problem, I know that I immediately can fix the crossbite, in this case the anterior crossbite, and will gain a little bit of space for my anteriors. And this is how we look. This is the split of the suture. Okay, and this is how she looks now. So we made some space for the lateral, okay, and we control the vertical, and this is how she looks. So now I have plenty of space for the lateral. And I'm gonna show you something here. Look at those canines. So when we first started, this case was a little bit early, but we wanted to intervene in that time. Now, after the expansion, okay, we wanted to see those canines did not actually improve in position. So now we're going into extraction of those primary canines. Primary canines extraction is a very big topic. It's very well known in our orthodontic practice. We extract primary canines to improve the position of the canines. For me personally, and I'm doing a randomized clinical trial on this with Dr.Marmin, is also one of the PhD students. For me, I really like to do them, but in certain cases and in certain severities, and I almost usually always like to give it a little bit of a try first before extracting them, because I do take care of the intercanine width increase, especially in growing patients. So I want to give it a chance, and then if it doesn't improve, and also cases that needs expansion, if it doesn't improve, then I go for the extraction. So I try usually to delay it, but I put this patient in a very close recall routine. So then I always check my treatment objectives. So for here, we controlled the vertical, we improved the crowding, we corrected the overjet, and we are evaluating the canines, and we're probably gonna do some extractions. So this is Eileen's case. It's one of the cases that I really like because it's very purely interceptive case. So a little bit of a small talk, and this stream is going to end very soon. Again, I don't want to repeat myself so much, but in open bite cases, you really want to be careful in recognizing the cause of the open bite. Is it a skeletal open bite or is it a dental open bite? Usually skeletal open bite can be associated with dental component, meaning if you have an open bite, then the patient will push the tongue forward when it swallows, and that will cause a further worsening of the condition. So how do you know that there is a habit? So if you look here, okay, usually overjet increases, overbite decreases, and you'll see that there is a decrease in the width of the canine and the molar. You will see a decrease in the width. So when does the guideline recommend stopping this habit? 6 months or younger, and that's always a question I bring in the exams for the board, for any orthodontic exam. I always bring this multiple choice question. By the age of 36 months or younger. So the younger the patient, the more likely of most of these dental problems will disappear. Okay, I really like the non-dental intervention. It actually works, believe it or not. Just straightforward discussion, building that rapport and building that relationship with your pediatric patient is amazing. They will do anything for you. You can put an adhesive bandage, elastic bandage, and the child should understand that this is not a punishment. The best way to stop a habit is actually for the child to want to stop this habit. My personal favorite is actually this, the arm brace, because most of the children, I ask them, when do you suck the thumb? And if they say at night and they do want to stop, this is going to be your best friend. You basically, when they wear their PJs, they wear this, and they brush their teeth after they brush their teeth, of course, and then they go to bed, and bam, they just stop doing that because they have this brace and they do want to stop. So it does work. For the pacifier, this is actually my mentor invented this. This is the Lily method to stop the pacifier habit early. You can find it on Amazon. It's basically a cut pacifiers, but it is a gradual, so usually they have very positive results with it. So hello, Dr. Eileen. Okay, the crib, my take on it, I've used it, I've done it in a lot of cases, and this picture is from husband, Dr. Osama Basri. He likes to measure his open bite, and he likes to use that tongue crib as well. But now recently I've been leaning more toward using the bluegrass supplies for habit, because it's a reminder, it looks nice, and the child actually leave the clinic without feeling that he's punished. I don't do spurs anymore because the way they look, and it's actually very harsh on the tongue. And you don't want the child to feel that. They actually leave with this, and they feel that they won a prize, or they got a toy or something like that. And you let them choose the color, and that actually increases the compliance. Another question I get for some cases is when to extract the sixes. And when is it a good time for the sevens to follow? Like this case, and courtesy to my dear student, Dr. Jamila, that she brought this case to me, and she was consulting regarding extraction of the sixes. So usually the students consult with me. So here's the thing: if you need to extract the six, or the six is you go ahead and extract it. However, the perfect time for compensating extraction is actually this time, when the furcation of the 7 starts to erupt and you have an 8. So if I have an 8 and I have bombed out 6s, like you can see here, this is really a bombed out 6 on the top. This is very close. Will probably need indirect pulp capping and stuff like that. And I have a very clean 7 over here, and I have the 8. So actually this is a perfect case for extraction of those 6s. Look here. So balancing extraction is usually done on the anterior teeth when you need to extract the opposite side from the same arch to minimize the central lines, and compensating extraction is actually extracting the tooth from the opposite quadrant to the enforced extraction. Because if you look here, what will happen if you extract this and don't extract this? This will over erupt. This will prevent the 7 from completely filling the space of this tooth. So let's say if the mother refused to extract, the upper 6s, you need to put a vertical holding appliance or something to control the vertical to prevent those teeth from super eruption, and actually jeopardize your excellent treatment. Maybe not a lot of people will like this case, but this is what it is. Anyways, this is another case. This is a 9-year-old came to us with bombed out teeth, and the mother chief complaint was actually orthodontic treatment because of this moderate crowding. This case is courtesy of Dr. Dua Jamal, my dear student as well. She's an M4 now. But anyways, so very sorry about the connection, but if you look at this case, you see here is roughly moderate. She placed an ounce because of the long span here. Please do not put TPAs on these cases, because I know the nance is non-hygienic and stuff like that, but nothing will hold this amount of space. A TPA, if you put a TPA in this case, what you will see is the molars very shifted all forward, and you will impact all of your posterior teeth. Anyways, so this case, the canines actually needed heavy restoration, and the mother is concerned about the crowding in this case, so we opted to extract both canines. Do not extract one canine. You need a balancing extraction in this thing. And we are placing a lower lingual holding arch anyways, and this is the case how we're maintaining our E-space, and this is a very simple interceptive case. So I hope the cases I showed were helpful. It's very hard for me to extensively explain everything. Interceptive orthodontics, I give this course over 2 to 3 days. And I give it in the masters over a whole year. A lot of cases, a lot of discussion. The more you discuss the cases, the more you learn. You have my Instagram account. I usually answer within a day or two. If you have cases you need to consult with me, you can just send me good records and we can have discussion and we share opinions. I think one of the last questions I got was about serial extraction, and they were asking me if it was outdated. Or if it works or not, something like that. So my take on serial extraction is that I do not like to do them, but it's not because they're not good. They're actually good and it works, and I've seen beautiful cases done with serial extraction. However, if the choice or the case selection was good. So most of the cases that comes in crowded, they usually have skeletal components, and usually this is what happened, that the dentist or the dentist they say, oh, this case is very crowded and we want to do serial extraction. I say no, because this patient is skeletally class 2. So if you're extracting 4 premolars, which is the extraction pattern for serial extraction, your extraction a class 1 extraction pattern for a class 2 case, and you will end up ruining this case for the orthodontist to be able to finish it nicely later on. So that's why I don't do much of them. Also, because of cooperation, I always concerned about the fear. This is because I'm a pediatric dentist, and we have a little bit of issue for accessibility of care with regards to sedation and stuff like that. I don't want to lose my patient. If I extracted 4 permanent teeth, I might jeopardize his patient cooperation and his willing to come for his recall and regular checkup, which is more important than elective orthodontic treatment sometimes. So this is the reason, it's one of the reasons for me that I do not do serial extractions anymore. If I'm gonna extract, I'm gonna extract later. So I do extract. I like extractions, but I don't do them. I don't do them early. If I'm gonna do extractions, I do them later.